of you out there. At the outset, I would like to begin by thanking Day for the invitation, and I would also like to congratulate them for the activities that they conduct. You're even conducting on a Sunday, so that shows your passion for the subject and your work. So, without much delay, let me just delve into the subject because I've been given three important topics: critical care, CKD, and liver disease in diabetes. Usually, what happens is that in a diabetic patient, the focus is either on the sugar control or it is on the disease. But a combination really poses a lot of problems where the part of the thing gets a little neglected. So I would like to begin with dysglycemia or glycemic problems in the ICU. So what do we mean by the term dysglycemia? It typically means either hyperglycemia or hypoglycemia, or the third is glycemic variability. This is a new concept which we had been neglecting, I think, over the years, where you find that the blood sugar actually fluctuates. And now we know that this glycemic variability is worse than either persistent hyperglycemia or hypoglycemia. So any of these in the critical care unit leads to poor outcomes and significant mortality. A common feature that we see in the critical care unit is that the doctors, the nurses, the dietitians, everybody, they are so focused on the problem that the patient is brought in with. It can be a traumatic stress, it can be the infection, that usually the management of diabetes takes a back seat. And that is when the illness starts worsening. Because we know that dysglycemia, it worsens any critical illness because it leads to decreased immune function and increased oxidative stress. So no matter how well the treatment is going on, if the glycemic variability persists during critical illness, the outcomes are really not commendable. Next slide. So how do we first start? To begin with, screening the diabetic patient in the ICU is very important because not all patients will come to you with the typical glycemic symptoms. You may have patients who were not diabetic earlier, but they show very high sugar levels. So screening the unrecognized diabetic is very, very important. I have personally seen many people coming into the ICU and then getting screened for diabetes. And then we find that the person has been diabetic for quite some time, but he has never actually tested the sugar levels or followed it up. We even find people coming and saying that we've taken herbal medications, I've been walking, I don't feel anything, so I do not go to the doctor. So the damage that has been done is already there, and the addition of stress in the ICU actually aggravates the situation. So screening the unrecognized diabetic is the first step. The next step involves evaluating the parameters like HbA1c, routine blood sugar, lipids, and so on. It may be that the fasting sugar is high or the glycemic control is completely out of hand because of the disease, but his HbA1c is under control. So it's a sudden onset disease. Or it also can be that the blood sugar is marginally high, but the person is a certified diabetic and he shows very badly controlled diabetes in the way of HbA1c being very high. So we get both types. The anthropometric measurements, of course, as much as possible. We do know that in the ICU that it is always not very, very validated. It's very difficult. But even then, the basic anthropometric measurements, it's very important to take the past clinical history and, of course, the drugs, the inflammation, and the disease as contributors. So any kind of hyperglycemia in the ICU will have the disease as a background, the use of steroids, and the chronic underlying inflammation. So that is how we start with screening the diabetic in the ICU. Now, we have certain acceptable glycemic targets. These have been decided by doctors by consensus statements that glycemic variability should be minimum in the ICU. Once the patient is showing say a blood sugar level of 90, the next moment it is 250. This is something which is absolutely unacceptable. We should all have a target glycemic control and we should fix this range in our different ICUs. It may not be identical for all ICUs, but every ICU there should be a consensus amongst the doctors, the treating clinicians, the nurses, the dietitians, that we should have a range, a preferred range in the ICU for glycemic control. Usually for medical and surgical ICU patients, it has been kept at 140 to 180. milligram per deciliter, and hypoglycemia below 110 should be strictly avoided. So extremely stringent conditions in the ICU is probably not a good idea to go about with. Next slide. The Indian practice guidelines for the ICU management of critically ill patients states the routine blood sugar should be more than 140 with an HbA1c of around 6.5%. But HbA1c measurement is compulsory for all known diabetics if routine blood sugar exceeds 140. Usually we miss this out in the ICU. HbA1c over 8.5 is a strong indicator for postponing of major elective procedures. This is not always done because people tend to just see the routine sugar. Okay, the sugar is maintaining fine. Let me increase the insulin. Anyway, the patients are kept fasting or semi-fasting before an OT or a procedure, and the people just take the patient up for surgery. But it is very, very important to see the HbA1c, which gives a very clear indication of the glycemic control before we take the patient up for any major elective procedure, because this can go a long way in the outcome. Next slide. So the important nutritional considerations in hyperglycemia management is that we should control hyperglycemia with first low glycemic index foods. But in addition to that, it is important to increase the fiber content, and 20% of energy should be from protein. So it is not just about the carbs. We generally first jump to carb, low carb, high carb. We cannot do without the carb, but the carb should be of low glycemic index with the addition of two things. One is fiber and concentration on the protein. Next slide. So the carbohydrate management in the ICU should be managed with consideration of the GL and the GI rather than individual carb ingredients. So none of us eat foods in isolation. So if you're giving the patient food, you should not think about the individual food that you're taking or the carbohydrate content, but rather the conglomeration of all things. Usually in the ICU, the patient cannot eat. So we have to give them supplements, or they take foods mixed, one food mixed with the other. You're adding some protein powder to the juice, or maybe to the soup, or maybe the dal and the sabji and the rice are being made into a blenderized khichdi and given to the patient. So we have to take into account the overall GL and GI index, not the individual carbs. And the carbs need to be spaced out evenly during feeds. Anyway, the patient will not eat well. And the problem is that sometimes they eat, sometimes they don't eat. So the carb spacing is usually not done properly. Low GL-GI feeds are effective for the management of dysglycemia. And of course, scientific formulations provide more accurate GL-GI values than kitchen-based feed. Next slide. The protein composition of foods, the effect of it on dysglycemia. There is a lot of controversy that what is the total protein intake, the ideal total protein intake, or should we concentrate on certain amino acid compositions or not. But we still have certain doubts. The efficacy of high branch chain amino acid over aromatic amines in protein content. We still do not have a specific cutoff point which says that this is the maximum or the minimum protein delivery for optimal glycemic control. It's very, very individualized. It also takes into account the patient's other factors like renal parameters, digestibility, and so on. Isolated reports of high incidence of glutamic acid have been shown to actually increase the risk of dysglycemia. So now we are over that phase when we just add glutamine unnecessarily. The effect of whey and casein on GLP-1 secretion or their ideal combination still not clear. We know that it has a positive effect on GLP-1 secretion, but we still do not know the ideal composition. And the timing of protein delivery is also very, very important, which is something, again, which we tend to overlook. The patient does not eat, or it may be that the planning of the diet is such that in one meal pattern, you'll find an overdoing of carbohydrate, and in another meal, you have only proteins. That is not recommendable. And also, if we can give the protein at the correct time, especially after the patient has been mobilized, after a little bit of activity, it actually helps in building up the muscle and for proper glucose control. So basically, the carbohydrate and protein management both are very, very important in the critical care unit. And we have to keep in mind that in the critical care, the entire scenario is very, very different from the normal scenario. The normal person who is eating, drinking, moving about with normal digestion, management of that dysglycemic patient is very, very different from the critically ill patient who not only cannot eat, who has got underlying inflammation, disease processes to contribute to dysglycemia, and also the entire substrate metabolism is altered in such patients. Next slide. So why do we usually go for GTSN or glycemic targeted specialized nutrition? I'm sure all of you know that many clinicians, many patient relatives, many patients themselves, they object to having these powders, as they call them. But the reason is that there's a growing body of evidence that in patients with type 2 diabetes, both day-long and bolus consumption of a GTSN is associated with improved glycemic control and improved insulin resistance as compared with standard nutrition formula. We do not need to stuff them with sugar, and we also need to keep in mind the nature of the carbohydrate. So typically the GTSN, they are formulated in a way that they have a complex source of carbohydrate, they have added fiber, and they have good quality protein. So that really helps in glycemic control, and we have a good idea of the GI and GL the content throughout their stay in the ICU, as opposed to blenderized feeds or feeds which are formulated in the kitchen. Next slide. So there are certain practice guidelines which have been recommended for the management of this glycemic index and carbohydrate loading and their clinical evidence. We find that the glycemic targeted specialized nutrition should be identified by its low GL and GI rather than individual carbohydrate ingredients alone. So it may be that some formula has got a little bit of fructose or a sucrose added, and we start jumping up, okay, this is not right. But rather the entire whole thing should be taken into account, not just the individual carbohydrate. The conglomeration should be taken into account. The GL and GI are precisely known for the scientific formulations, which is a very big advantage. And low GL GI is an important parameter with regards to feeds for dysglycemic patients. This I think I've already mentioned. Next slide. So other practice guidelines include that in order to target glycemia, purely low carbohydrate feeds may not reduce postprandial glycemic variability. There can be more fluctuations, as a matter of fact. So GTCN low in GL, GI, and containing also the optimum protein and a good quality protein is actually good for the management of a diabetic patient. If the person is diabetic, then of course, even if the patient is not diabetic, he has some impaired glucose tolerance, or maybe the sugars have suddenly gone up due to the use of steroids or due to the underlying inflammation, we can use this formula also for non-diabetic patients. The protein and electrolyte content of a GTCN should be taken into consideration if you are dealing with renal or hepatic patients, or those who have a fluid and electrolyte imbalance. For fluid restricted diet or for some other parameter which is T range, the protein and electrolyte content of a GTCN should be considered before imparting it to the patient. Feeds containing complex and slowly digestible carbohydrates with a combination of MUFA really help in glycemic optimization in critical care settings. And we know that MUFA through natural food, it's very difficult. So these formula, they really come into help. So at the end of the day, mixed nutrient feeds, including high-class proteins, complex carbohydrates, a bit of MUFA, and the addition of prebiotics used in GTCNs or in any kind of feed that we formulate in the kitchen. It's very difficult to do it. But so we have to take the use of these formula feeds. But this combination is ideal for the dysglycemic ICU patient. Next slide. So the preferred blood sugar range for ICU patients, medical or surgical, should preferably be kept at 140 to 180. Hypoglycemic episodes should be minimal. If the person has a routine blood sugar of 140, if he's maintaining that, the HbA1c should be measured, and we take the patient to be diabetic if the HbA1c is over 6.5 or and routine blood sugar is more than 140. The blood sugar measurements should be done 4 hours in continuously fed dysglycemic patients. The frequency of blood sugar management should be 7 times a day in orally or bolus fed patients, because if we are feeding the patient continuously, the probability of the sugars being under control is higher. So we can do the measurements every 4 hours. But if we are giving bolus feed or the patient is on an irregular diet pattern, it is all the more important that we do the sugars more frequently. Next slide. So now we come to the special cases where the patient probably has a renal impairment or a hepatic impairment with diabetes. So we can give GTCN to neuro ICU patients because there is no problem. But what about the renal patients and the patients who are on dialysis? In a renal low specific feed, low GI/GL feed is recommended, but optimum protein and electrolytes also need to be looked into before imparting that to the patients. In patients requiring dialysis, we also need to concentrate on their high protein, but at the same time, low electrolyte balance while choosing the renal specific feeds. So here, it is not just about the low GL/GI to manage the carbs. It is also about the electrolytes, the quality of protein, and so on. For hepatic patients, without much of specific requirements of protein, without hepatic encephalopathy, the non-compensated decompensated liver patients, we can sometimes give the standard GTS and it's not a problem. But if we come across a very severely ascitic patient or somebody in acute liver failure or the decompensated liver failure patient, we might have to think otherwise in terms of fluid management, electrolytes, and so on. Next slide. So we know the stages of chronic kidney disease and the relation with diabetes. If we are dealing outside the CCU, we find that people, they come to us at the stage 3 or even stage 4, because diabetic kidney disease is a silent killer. And stages 1 and 2, we usually find that there is no demonstration, no clinical symptoms. Even in the stage 3, we rarely find much clinical symptom. So how do we actually manage these people? It's very important for us to know which stage of chronic kidney disease the person is in and accordingly manage it. Next slide. So the goals of CKD management should be, we should achieve and maintain optimum nutritional status depending on the level of the GFR. We need to prevent protein and energy malnutrition, which typically starts at stage 3 onwards, because that is the time when the patients start complaining of oral intake issues. We need to slow the rate of disease progression. It's important to counsel the patient that this is not absolutely reversible. So we need to slow the rate of disease progression. For that, regular checkups and a proper dietary management is required. But usually what is missed out is that the moment we talk of kidney, people only concentrate on protein and nothing else. Okay, I have kidney disease, I do not want to take protein. At the early stage, stages 1 and 2, I think it is far more important to concentrate on the energy management, the healthy lifestyle. We can give proteins to the patient because a urea, creatine, or even microalbuminuria is not absolutely out of hand. It is more important to keep the blood sugar under control. But we often find that the people, the doctors, the patients, the family members, they are only obsessed about the protein part. So we need to educate them that prevention and treatment of complications are there in CKD. It is not just about your kidney and protein. The diabetic control, management of hypertension, dyslipidemia, because every CKD patient has a chance of becoming a heart patient. So dyslipidemia and CVD should be taken into account. The chronic anemia. Anemia cannot be treated or cured by just putting in iron pills and giving them iron-rich diet, because the erythropoietin does not function well. Metabolic acidosis and secondary hyperparathyroidism and weight loss. So all these things have to be taken into account when we are dealing with diabetic kidney disease. Next slide. The optimum nutritional targets which we should keep in mind is to keep the albumin over 4, which is really very difficult. Stable, desirable, dry weight. The patient should not gain too much weight, but at the same time, chronic weight loss is also not desired. Adequate fat stores and muscle mass, and appropriate appetite and intake. These 4 should be our targets in management of CKD patients. Next slide. So we know the protein guidelines for CKD patients. For those in stage 1 to 3, it can be easily, say, from 0.8 to 1 gram. It's rather individualized. If I find a patient who's very cachectic and he has apparently no other symptoms, I might go up to even 1 gram. 0.75 grams for stages 4 and 5, and 60% of the dietary protein should be high biological value protein. Next slide. So for diabetic nephropathy, stages 3 and 4 are the times when we should be very, very careful, where optimum glycemic control is very, very important, and we need to avoid hypoglycemia, because this is the time when the patients go into hypoglycemia and they have the feeling that my diabetes has been cured. It is not that it's been cured, it's just that the kidneys are worsening. So with proper glycemic control, potassium restriction, removal of irritants from the diet, the nephrotoxic factors, management of sodium, and additional nutritional supplement, we have to keep the patient well managed. Next slide. So I think I can skip.
Yeah,
I'll just skip this slide. I think all of you know. I'll just say 2 words on the liver. We can skip these. So one point I need to mention is that for ICU patients, we usually have AKI, acute kidney injury. So there the management is quite different from the chronic CKD patients, where we have to give them a high protein diet and we have to monitor on a daily basis. And the fluid management will depend a lot on the kind of infusions that are going in and the diuretic effect and the dialysis and so on. Now, diabetes and CLD frequently coexist, and it's very challenging because we do not know sometimes what to do with the carbohydrate. We need to give carbohydrate, but at the same time, we need to restrict carbohydrate. So ideally, the choice of carbohydrate has to be taken into account, and the management of patients with diabetes and CLD may be improved if we have a multidisciplinary approach. Next slide. There is something called hepatogenous diabetes, which is diabetes coming out of the impaired liver. It's the other way around, where the liver cirrhosis leads to insulin resistance, deterioration of beta cell dysfunction, which causes IgT and can lead to hepatogenous diabetes. Next slide. So we know the MNT, the aims of MNT for hepatic patients. I'm not going into the details. We have to manage them just like any other hepatic patients, only keeping in mind that these patients are very liable to go into hypoglycemia from time to time. And we have to make sure that they get small, frequent feeds, and the nature and distribution of carbohydrate should be very, very important. Next slide. I'm not going into the dietary principles. We know the stages of encephalopathy and the management of encephalopathy. We do not completely omit proteins from the diet. We do it gradually. We avoid animal proteins. We increase proteins gradually as the coma subsides, and proteins should be preferably from BCAA, but we do not completely restrict proteins in HE as was earlier the case. So in the classic liver failure patient in ICU would be managed like any other critically ill patient, with a high calorie, high protein diet, with a multidisciplinary management, with the fluid management, the electrolyte management. We have to do it in conjunction with the doctors, and accordingly we need to select the feed, and we need to let go of the old concepts that people with liver disease should not be given protein. Next slide. So good glycemic control is indispensable in the critical care, renal and hepatic patients. One last thing I would like to mention is that we always need to remember that any patient who has an impaired kidney or liver, they are 2 to 3 times more prone to hypoglycemia than the normal diabetic patients. So we have to keep this in mind. And at the background, no matter how critical the patient is, if the concentration is entirely on the renal and hepatic parameters or the critical care parameters and the blood sugar part is ignored, then we are going to get very poor outcomes. So with that, I end my session. Thank you for your patient listening. It's been a little too long, but I'm sorry the topics were quite huge.
Many thanks.